Okay, let's unpack this. We're about to take a deep dive into a really complex area of veterinary medicine, something that can be, well, incredibly challenging for pet owners and vets alike.
Absolutely. We were talking about polyneuropathies, often called peripheral neuropathies. These are conditions that affect the nerve connections throughout a dog or cat's body.
And our source today, it actually comes directly from you, our listener excerpts from a veterinary reference text, specifically on canine and feline polyneuropathies. So thank you for sharing this window into such a detailed topic.
Yeah, it's great material.
Yeah.
And our mission here is really to navigate this complex information, pull out the most important insights. We want to understand what these conditions fundamentally are, the surprising variety of things that can cause them,
Right.
how they actually show up in our pets, and what that whole intricate process of diagnosis and management looks like.
And here's where it gets really interesting, I think. These conditions, they're kind of like medical chameleons, aren't they? They can manifest in so many different, sometimes really unexpected ways, affecting how a pet moves, feels, even how their internal organs function.
Exactly.
It must make pinning down exactly what's wrong a significant puzzle, a real piece of detective work for the vets.
It certainly can be.
Yeah.
So let's start with the basics then. What exactly are polyneuropathies? Drawing from the material you provided, they're defined as diseases affecting the peripheral nerves.
Okay.
Think of the peripheral nervous system as like this vast network of wiring connecting the central command center, the brain and spinal cord, to actually everything else in the body. Muscles, skin, organs, sensory receptors.
Right, like the miles of electrical wire in your house, maybe, connecting the main breaker box to every light switch, every appliance. If there's a problem in that wiring network, things just don't work right downstream.
That's a great analogy. And the text gets into the underlying problems too, the pathophysiology.
Ah.
That's where we see the two main types described: axonal neuropathies and demyelinating neuropathies.
Axonal and demyelinating. Got it.
So axonal problems mean damage to the wire itself, the nerve fiber, the axon. This can start with problems in the nerve cell body itself. They call those neuropathies. Or it can be degeneration of that fiber further down the line. Those are called axonopathies.
Okay, damage to the wire. And demyelinating, that sounds like damage to the insulation around the wire.
Precisely. Nerves have this fatty wrapping called the myelin sheath. It's like the plastic coating on an electrical wire. It insulates the nerve and helps signals travel super fast and efficiently.
Mm-hmm.
When that insulation is damaged or missing, well, signals slow down, they can get scrambled, or sometimes they just stop altogether.
And even though the name peripheral suggests, the edges, the text notes, these primarily affect the peripheral nervous system, but can sometimes involve the central nervous system too.
That's right. Plus, if the nerve problem is actually secondary to another disease happening elsewhere, you might see signs in other organ systems as well. It gets complicated.
Definitely sounds like it. So that gives us a picture of the what. But understanding the what immediately leads to the next big question. Why? Why does this happen? What causes these nerve problems?
And the list from the document is, well, it's pretty extensive. It really highlights how many different things, internal or external factors, can impact these delicate nerve pathways.
Yeah, I was looking at that. It's a lot.
It is. They categorize the causes into two main groups: inherited, meaning they're passed down genetically,
Okay.
and acquired, meaning they develop later in life due to, well, various triggers.
And those acquired causes, looking at the list, it seems like everything from like internal body chemistry going wrong to, outside exposure.
Exactly. The text breaks it down further. You've got degenerative conditions where nerves just sort of break down over time.
Okay.
Idiopathic ones, which is just the medical term for we actually don't know the cause.
Right. The mystery
And
category.
significantly, metabolic or endocrine diseases. Things we see fairly commonly, like diabetes, hypothyroidism, Cushing's disease, hyperadrenocorticism, are specifically mentioned as potential culprits.
That makes sense, actually. They're systemic diseases. They affect the whole body, so it follows they could mess with the nerves connecting everything.
Precisely. Next up are neoplastic or perineoplastic causes, so issues linked to cancers.
Ah.
And this is fascinating because the cancer doesn't always have to be like directly pressing on a nerve. It can release substances that interfere with nerve function elsewhere in the body. The text lists examples like insulinomas, certain carcinomas, melanoma, mast cell tumors, osteosarcoma, multiple myeloma, lymphosarcoma.
Oh, so a tumor hidden somewhere, say in the abdomen, could actually cause weakness in the legs. That's That's a critical insight.
It's a key mechanism for these paraneoplastic syndromes. Really shows how interconnected the body is.
Hmm.
The material also covers immune-mediated inflammatory causes.
Okay, autoimmune stuff.
Yeah, these can be primary nerve issues, or they can be secondary to other autoimmune diseases like SLE lupus or glomerulonephritis, which is kidney inflammation, or polyarthritis, joint inflammation.
And infections made the list too.
Yes. The text specifically names Neospora conanum, that's a parasite, and then feline leukemia virus, FLV, and feline immunodeficiency virus, FIV.
Mm.
And finally, drugs or toxic substances can trigger polyneuropathies. The document gives some really concrete examples. Certain chemotherapy drugs, fibrostine, vinblastine, cisplatin, and also environmental toxins like thallium or getaphosphates. Even certain feed additives like salinomycin in cats and lacilocid in dogs.
That is quite a dizzying array of potential triggers. Are there specific things that make a pet more at risk for these?
Well, the text points out that having those underlying metabolic, immune, or neoplastic diseases, that definitely increases risk significantly.
Stands to reason.
Exposure to the listed drugs or toxins is obviously a factor too. And here's a really specific, almost surprising one. For a condition called canine hypothyroid polyneuropathy, or CHP, contact with raccoon saliva is noted as a potential causal factor.
Raccoon saliva, seriously. Causing nerve damage. That's one of those nuggets you just wouldn't guess.
It's a very specific detail from the material, yeah.
So, knowing the causes, who is more likely to be affected? Is this something we see, like, everywhere in all breeds, all ages?
The incidence varies quite a bit, actually. Inherited types are generally considered rare.
Okay.
Inflammatory ones are uncommon overall, but that raccoon-linked CHP is mentioned as the most frequent inflammatory type. For the neuropathies that are secondary to metabolic or neoplastic diseases, the overall frequency, well, it isn't precisely known from this text.
And the geographic details were really striking, too. It's not always a global thing.
No, it really pins down some conditions.
Yeah.
CHP, for instance, is noted primarily in North and Central America, plus parts of South America. Distal denervating disease is specifically mentioned only in dogs in the UK, not reported elsewhere, according to this source.
Only the UK, huh?
And dysautonomia that affects the autonomic nerves controlling automatic functions like digestion, heart rate, that's mostly seen in dogs in specific areas of the U.S., like Missouri, Oklahoma, Kansas. But it also affects cats in Scandinavia and the UK.
That geographical specificity really makes you wonder about environmental factors or maybe regional genetic things. And then there's the deep dive into breed predilections. This is where those inherited types really stand out, doesn't it?
Oh, absolutely. The text gives numerous examples. It shows how specific genetic lines can carry these risks. For something like spinal muscular atrophy, you see breeds like Brittany Spaniels, German Shepherds, Dobermans, even Maine Coon cats listed.
Wow.
Axonopathies, those problems with the nerve fiber itself, they affect breeds like German Shepherds, that's giant axonal neuropathy. Boxers get progressive axonopathy. And several large breeds like Rottweilers, Alaskan Malamutes, Great Danes, Leonbergers, Bouvier de Flandre, they can get distal sensorimotor types. They even list specific cat examples, like the Burman and Snowshoe.
So your pet's breed can unfortunately be a pretty significant risk factor for certain types of these nerve conditions. What about the myelin sheath problems, the demyelinating types?
Yeah, those have their own list too. Conditions seen in the Tibetan Mastiff, that's hypertrophic neuropathy, golden retrievers can get, congenital hypomyelination, miniature schnauzers, a demyelinating type, and Bengal cats are recurrent demyelinating neuropathy.
And those lysosomal storage diseases, that sounds like a whole category affecting many different breeds.
It is. These are genetic disorders where the body lacks a specific enzyme needed to break down certain substances, and those substances build up in cells, including nerve cells. It's quite damaging.
Right.
The text lists a lot of breeds prone to these: Westies, Cairn Terriers, Springer Spaniels, Persian cats, Siamese, Karat, Balinese, Norwegian forest cats. It's a long list.
And sensory neuropathy, the ones affecting how a pet feels things.
That also has its own list of predisposed breeds from the source: long-haired dachshunds, English pointers, Jack Russell Terriers, border collies. For the acquired conditions, the text notes a higher incidence of CHP, specifically in coonhounds, which ties back to that raccoon connection we mentioned.
Ah, right.
And diabetic neuropathy is clinically much more common in cats than dogs. Insulinomas, that cancer cause, seem more frequent in breeds like German Shepherds, Boxers, Irish Setters, Standard Poodles, and Collies.
So breed definitely plays a huge role, especially for the inherited types. What about age? Does the age of onset give us clues?
Absolutely. Inherited conditions, they often show up early, typically under 6 months of age.
Young puppies and kittens.
Mostly, yes.
Yeah.
But there are exceptions the text highlights. Some of those large breed types, like in Rottweilers, Bouvier, Leonbergers, they can start after a year old. Or that giant axonal neuropathy in German Shepherds kicks in around 14, 16 months. Acquired neuropathies, on the other hand, usually affect middle-aged to older animals if they're related to cancer or insulinoma. But infectious causes like Neospora polyreticuloneuritis often strike dogs under 6 months. And another type, ganglia radiculitis, is typically seen in dogs over 1 year. So age is definitely another piece of the diagnostic puzzle.
Okay, so we've got a handle on what these conditions are, a huge list of potential causes, and who might be more predisposed. Now, the crucial question for any owner or, a vet trying to figure this out is, what does this actually look like in a pet? What signs might you see at home or on examination?
Right, the clinical picture. The document describes both historical findings, what owners typically notice and report, and physical exam findings, what a vet specifically looks for.
Okay.
For inherited conditions, owners often report progressive weakness. The text uses the term LMN tetraparesis,
LMN.
lower motor neuron. Those are the final nerve wires going out to the muscles. And tetraparesis just means weakness in all 4 limbs.
Gotcha. Weakness in all 4 legs from problems in those final nerve pathways.
Exactly. You might also see muscle tremors and muscle atrophy that's muscle wasting. And specific kind of weird stances like walking flat-footed on the hocks that's plantigrade or on the wrists palmigrade.
Oh, yeah. I've definitely seen photos of cats with diabetic neuropathy standing like that. That plantigrade stance is so distinctive.
It really is. And if the condition affects the nerves to the voice box laryngeal paralysis, owners might notice voice changes or noisy breathing, what they call stridor. Sensory neuropathies, where feeling is the main issue, are different. The text notes signs like self-mutilation.
Mutilation.
Yeah, chewing on limbs because they don't feel normal pain or sensation properly. It's distressing. And also ataxia, which is incoordination or wobbliness.
And these lysosomal storage diseases you mentioned earlier sound particularly severe.
They often are. The text indicates they frequently affect both the peripheral and central nervous systems. So you get signs like tremors, more severe ataxia, seizures, blindness, even dementia layered on top of the LMN signs. And a rapid onset is noted for that giant axonal neuropathy in German Shepherds, generalized weakness developing in less than 3 weeks. Pretty dramatic.
Wow. What about the signs for acquired neuropathies? Do they look different?
Their onset can be either rapid or slow. Conditions like CHP or that distal denervating disease, they can start with just a stiff gait and then quickly progress to severe weakness or even paralysis within days or weeks.
That sounds terrifyingly fast.
It can be. Others, though, like diabetic neuropathy or those linked to hypothyroidism, tend to develop more slowly. You see generalized weakness and muscle atrophy creep in over time, often leading to those classic stances, like the plantigrade one.
That dysautonomia you mentioned, that sounds like a particularly alarming presentation, too.
It often is, yeah. The text describes an acute onset, often within 48 hours, with a really distinct set of signs affecting those automatic body functions. Owners might see depression, loss of appetite, vomiting, severe constipation, or the gut essentially just stopping. That's called ileus.
Okay.
Very dry mouth and eyes KCS, or keratoconjunctivitis sicca. And the third eyelid might be protruding, covering part of the eye. Urinary incontinence is also common.
So a whole collection of strange signs hitting quickly.
Exactly. And with the metabolic or perineoplastic causes, owners might also notice signs related to the underlying disease itself, which might actually be more obvious than the nerve signs, at least initially. The primary tumor might be hidden, for instance.
So the vet takes this history from the owner and then does a physical exam. What are they looking for specifically? What confirms the suspicion?
Well, for the motor and sensoromotor types, the classic findings on exam are weakness, ranging all the way to complete paralysis. They'll check reflexes, which are usually reduced or completely absent. Muscle tone is decreased, and you can often see that muscle wasting, the atrophy. Tremors are also frequently seen.
Okay. And for sensory types, where feeling is the main issue?
There you'd see proprioceptive deficits. The pet doesn't seem to know where its feet are in space, and reduced to absent sensation to touch or pain stimuli. Crucially, the text notes these often occur without significant muscle atrophy or reduced reflexes, although boxers with progressive axonopathy are listed as an exception.
Interesting.
You'll see sensory ataxia, that incoordination because they can't feel properly, and sometimes paresthesia, that kind of tingling or abnormal sensation, especially mentioned in cats with diabetic neuropathy, and other sensory types.
Are there specific exam findings that might point towards particular underlying causes, like clues in the exam room?
Yes, definitely. The text links hypothyroidism specifically not just to generalized neuropathy, but also cranial nerve issues like laryngeal or facial paralysis, a condition called megaesophagus, where the esophagus is enlarged and floppy, and sometimes balance problems, vestibular signs.
Mm.
Lysosomal storage diseases often involve organ enlargement. Hepatosplenomegaly, meaning enlarged liver and spleen, is common. The vet would obviously be looking very carefully for any evidence of a tumor in suspected paraneoplastic cases.
Right.
Dysautonomia has those very specific signs on exam. A dry nose, confirmed dry eyes, KCS, usually a slow heart rate, bradycardia, and absence of the anal reflex. The text also mentions feeling palpable lipid deposits in cats with hyperchylomicronemia, that fat metabolism disorder,
Okay.
and enlarged, potentially painful kidneys in cats with hyperoxaluria, that genetic kidney stone disorder. Problems with other cranial nerves, like those controlling eye movement or chewing, are variable. Depends on which specific nerves are caught up in the particular neuropathy.
Okay, so given this incredibly wide range of signs and this huge list of potential causes, diagnosis really sounds like complex detective work. How does a vet even start to, figure out what's going on?
It absolutely is. And the document emphasizes that these conditions can mimic many other neurological or muscle diseases. So creating a list of differential diagnoses, all the possibilities, is critical first step.
Right, roll out the lookalikes.
Exactly. If the signs came on acutely, really fast, they have to rule out things like botulism, tick paralysis, myasthenia gravis, that's an immune muscle disease, or maybe sudden spinal cord problems. For chronic, slower signs, other muscle diseases, polymyopathy, or chronic spinal cord issues, myelopathies, need to be considered.
And standard lab tests like blood work and urinalysis, they aren't usually diagnostic for the nerve problem itself.
Correct. They're often normal regarding the nerves directly, but their huge value lies in pointing towards those potential underlying diseases we talked about, metabolic, immune, neoplastic.
Okay. Screening for the primary cause.
Precisely. High creatine kinase, CK, in the blood can suggest muscle involvement, maybe rule in a polymyopathy alongside the nerve issue, or just show muscle damage from the nerve problem.
What about more specific tests then to really pinpoint the cause?
Yeah, those are tailored based on what the vet suspects from the history and exam.
Yeah.
If an immune cause seems likely, tests like antinuclear antibody, ANA, or a Coombs test might be run.
Okay.
For hypothyroidism, obviously they'll check thyroid hormone levels, T4, free T4, TSH. An amended insulin to glucose ratio is key for diagnosing an insulinoma.
Right, that's cancer.
Blood tests looking for antibodies are used for infectious causes like Neospora FIV or FLV. Lysosomal storage diseases require specialized tests looking for diminished activity of specific enzymes.
And for dysautonomia, is there a specific test for that?
The text lists pharmacologic testing, so giving certain eye drops like pilocarpine or doing a challenge test with a drug called bifanical to see how the autonomic nervous system responds. It's quite specialized. For metabolic disorders, checking serum cholesterol and triglycerides is needed for hyperchylomicronemia. Looking for oxalate in the urine for hyperoxaluria.
Yeah.
And finding something called a monoclonal gammopathy, an abnormal protein in the blood, can point towards multiple myeloma as a paraneoplastic cause.
Okay, lots of specific blood and urine tests depending on suspicion. Does imaging, like X-rays or ultrasound, help in the diagnostic process?
Yes, primarily to search for those underlying tumors, especially in the chest or abdomen, which could be the source of a paraneoplastic neuropathy.
Makes sense.
Imaging can also reveal signs of dysautonomia, like that megaesophagus or the gut being paralyzed ileus or a very sole distended bladder atony or severe constipation, signs that fit the picture.
But the text called it the cornerstone for diagnosing the nerve damage itself.
Right.
It's electrophysiology, right?
Yes, that's where the really specialized nerve tests come in. EMG electromyography measures electrical activity in muscles, and nerve conduction studies measure how fast electrical signals travel along nerves. These give a direct assessment of nerve function. They can help differentiate between muscle problems and nerve problems, and also critically between axonal wire damage and demyelinating insulation damage nerve issues.
So that tells you what's wrong with the nerve, not just that something is wrong.
Exactly. Other procedures like analyzing the fluid around the spinal cord, a lumbar CSF analysis can help diagnose inflammation affecting the nerve roots where they come off the spinal cord.
Yeah.
A muscle biopsy can confirm if the muscle isn't working because it's not getting nerve signals. That's denervation.
And the nerve biopsy itself.
A peripheral nerve biopsy provides the most detailed look at the actual problem in the nerve tissue. Is it axonal degeneration? Is it demyelination? Are there issues with the nerve cell bodies? It helps characterize the specific type of neuropathy.
So the diagnostic process is really this multi-step funnel. You start broad with the history and exam, rule out mimics, look for underlying systemic diseases with standard tests, then use specific targeted tests based on suspicion, image to find hidden causes or secondary effects, and finally use these specialized nerve tests and biopsies to confirm and really characterize the nerve damage itself. It's truly fitting that it's described as detective work.
It absolutely requires piecing together clues from history, the physical exam, and multiple levels of testing. It's rarely straightforward.
So once there's a diagnosis, or at least a strong working diagnosis, what does the journey look like for treatment and management for these pets?
Well, healthcare is often managed on an outpatient basis, meaning the pet stays home mostly. However, the text does note that dogs with CHP, that coonhound paralysis, might need inpatient care initially for close monitoring, especially of their breathing, during that early progressive phase when they're getting weaker.
Okay, that makes sense.
Supportive nursing care is really, really vital. For conditions like dysautonomia, where the pet literally can't eat or drink normally, IV fluids are essential. And sometimes tube feeding is necessary just to maintain nutrition and hydration.
Right.
Physical therapy is also mentioned as important, trying to maintain muscle function and mobility where possible, prevent contractures.
What about diet? Is there like a universal nerve diet or anything like that?
Generally, no. No special diet is needed just for the neuropathy itself, unless there are complications like that megaesophagus or difficulty swallowing that require dietary modification. But the text highlights a couple of conditions where diet is absolutely key to treatment. For hyperchylomicronemia in cats, that fat metabolism issue, a low-fat diet alone can actually resolve the neuropathy completely within a few months, which is amazing.
Wow, just diet.
Just diet. And for diabetic neuropathy, which is particularly common in cats, successfully treating the diabetes, often with a low-carbohydrate, high-protein diet and insulin, frequently leads to reversal of the nerve damage over time.
That's really encouraging.
It is. And of course, there's the basic but crucial nursing care. Making sure paralyzed patients can physically reach their food and water. If there's severe regurgitation or vomiting, oral intake might need to be stopped temporarily, and a feeding tube might need to be considered.
And medications. The text mentioned that inherited conditions are, unfortunately, mostly untreatable. That sounds pretty bleak.
That's a hard reality the text conveys, yes. For the acquired neuropathies, the primary focus is always treating the underlying cause, with the hope that the nerve damage improves or resolves as a result.
Right. Treat the diabetes, treat the hypothyroidism, treat the cancer.
Exactly. However, the material is quite clear that this isn't always successful, or full recovery may not happen even if the primary disease is managed. The nerve damage might be too severe or permanent by the time it's caught.
Are there specific medications for the nerve problems themselves besides treating the cause?
Well, for conditions suspected to be immune-mediated, like that chronic relapsing, demyelinating neuropathy or SLE-related neuropathy, the text suggests trying long-term immunosuppressive therapy, using drugs like prednisone, azathioprine, or cyclophosphamide, though it notes the response is variable, it doesn't always work. If the neuropathy is paraneoplastic, related to cancer, then treating the primary tumor is the approach. Remove it surgically if possible, or use chemotherapy or radiation. For Neospora-associated polyradiculoneuropaths, that parasitic cause, there's a specific antibiotic combination recommended, clindamycin combined with pyrimethamine.
And for that really difficult dysautonomia?
Yeah, treatment there is mostly symptomatic, just managing the specific signs. So IV fluids for dehydration, artificial tears for the dry eyes, drugs like metoclopramide to try and help gut motility, and sometimes specific doses of bethanyl or pilocarpine eye drops to stimulate certain nervous system functions. It's very supportive.
There's a really important warning about certain medications in the text, right? About corticosteroids.
Yes, this is critical, absolutely critical, to grasp from the material. Corticosteroids, like prednisone, which are often used to suppress inflammation or the immune system, are specifically contraindicated.
Meaning definitely do not use them.
Exactly. They should not be used in Neospora-associated polyradiculoneuropaths, in neuropathy caused by Cushing's disease, hyperadrenocorticism, or in CHP, canine hypothyroid polyneuropathy, the coonhound one, Using steroids in these specific cases could potentially make the condition significantly worse.
Wow, okay, that's a huge take-home message. And communicating all of this complexity and the potential outcomes, the uncertainties, to the owner must be absolutely essential, but also really difficult.
It's crucial and, yes, difficult. The text stresses that owners need to understand that treating the primary cause might not fully reverse the nerve signs, that deterioration can continue in some specific types, unfortunately, and that canine axonal degeneration problems with the nerve fiber itself often leads to progressive decline. Managing expectations and providing realistic information is a huge part of the care process.
So, looking ahead then, what does the overall outcome or prognosis look like for these conditions? What are the potential serious complications owners should be aware of? And is there anything at all that can be done to prevent them in the first place?
Well, patient monitoring involves repeat neurologic exams over time. You have to carefully track if the pet is improving, staying the same, or sadly deteriorating.
And the prognosis, it sounds like it varies hugely depending on the specific type of neuropathy.
It absolutely does. The text highlights a key distinction. Demyelinating conditions, whereas the insulation that's damaged, generally have the potential for more rapid improvement compared to axonal neuropathies, where the nerve fiber itself is damaged.
Okay.
Axonal types can take months, sometimes many months, to recover, and even then, that recovery may only be partial, or sometimes it just doesn't happen at all.
And the inherited types.
For most inherited types, the text states the long-term prognosis is generally poor. The big exception mentioned is that feline hyperchylomicronemia, where the neuropathy can resolve completely just with diet change. But for most others, it's not good news long-term.
What about that more common inflammatory one, CHP, the coonhound paralysis?
Acute polyradiculoneuritis, or CHP, actually has a good long-term prognosis according to the text. But recovery is a process. It takes weeks, often months, for the nerves to heal and function to return.
Okay, so hope there, but patience needed.
Definitely. For metabolic neuropathies like diabetic neuropathy, the prognosis is considered fair to good if the underlying metabolic problem is successfully treated and controlled. But the text does note that insulinomas, one of the paraneoplastic causes, have a high recurrence rate even after treatment, which impacts the long-term outlook.
And many of the other acquired types, if it's not CHP or metabolic.
Sadly, the document indicates that many of those show continued deterioration despite treatment of the underlying cause. This really underscores the challenge with some of these conditions. They can be relentlessly progressive.
What are the worst-case scenarios then? The possible serious complications listed in the text.
Yeah, these are significant potential outcomes. Continued neurologic deterioration leading to the inability to walk at all, severe muscle atrophy and profound weakness, secondary issues like pressure sores from being down all the time, urinary tract infections are common, muscle fibrosis where the muscle gets scarred and tight, and aspiration pneumonia, which can happen if the pet has difficulty swallowing due to nerve issues and inhales food or liquid into the lungs. That can be life-threatening.
So, really serious potential consequences. Finally, prevention. Are there specific things mentioned in the text to try and avoid these conditions?
The text lists a few specific avoidance strategies drawn directly from known causes. For neospore infection, which can cause polyradiculoneuropathy, avoiding breeding animals known to have the parasite is recommended because it can be transferred placentally to the puppies.
Okay.
For CHP, avoiding contact with raccoons is mentioned as a preventative step, given that suspected link to raccoon saliva.
Right.
And the text consciously suggests, really on an individual case basis where a link was strongly suspected, considering avoiding future vaccinations. But that's a very complex decision. It has to be made in careful consultation with a veterinarian, weighing the potential small risk against the very real risks of the infectious diseases the vaccines prevent.
Absolutely. That's a nuanced discussion for sure. You
Yeah.
know, what's truly fascinating when you pull back from all these intricate details we've discussed is that interplay between systemic health, whether it's metabolism, the immune system, exposure to toxins, even infections, and the function of these peripheral nerves.
It really emphasizes that the nervous system isn't this isolated entity, is it? It's deeply, deeply connected to the entire body's health and what's going on systemically.
Yeah.
And this material, it really highlights the challenging reality for many of these conditions, particularly the inherited ones, where, well, our current knowledge provides no effective treatment. And that just underscores the ongoing critical need for more research in veterinary neurology. We need to find better ways to prevent, diagnose, and ultimately treat these often devastating diseases.
Well, that was truly a deep dive into the complex, sometimes surprising, and often challenging world of canine and feline polyneuropathies, drawn directly from that detailed source material you shared with us. Hopefully, unpacking these insights, the many causes, the varied signs, the real detective work of diagnosis, and the often variable outcomes gives you a clearer picture of these conditions and why they can be such a puzzle for everyone involved. Thanks for joining us for this deep dive.